It's my privilege now to hand over to Neil, who's already getting sort of nervous because I said it's a privilege. And I'm not going to ruin your line, Neil. So, as I say, I'm going to get you all to introduce yourselves this year.
Okay.
But Neil is a colleague of mine in Sheffield, and you'll be quite familiar with him. He does quite a lot of the articles around drugs, etc., in the Emphasis magazine. A lot of people say we look similar, and I find that really bizarre. I mean, he's old, he's a bit rack and ruin, he's got facial hair, and I've spent a fortune on lard and moisturiser, and clearly Neil hasn't. So, but I know in clinic we get confused quite a lot.
That's right. I'm giving away 5 stone in 10 years, but we look similar, eh?
Yeah.
So I'm delighted to be here, and it's an honour to be invited back. I think that's a sign that obviously something went right last time. So it's a real privilege for me. The aim of my talk, let's get the right one. No, that one don't work. The aim of my talk this morning is to just talk to you about medical management, so the treatments that we've got available for pulmonary hypertension, and how they fit in, hence the title of the jigsaw of pH. So that's what we're doing, and it's really been a success story over the past 20 years. The little block on the left, I like this Lego analogy, the little block on the left, that's where Ian came in. And the next one along is really where I see it that I came in. We had only one treatment option available, and that was IV 20 years ago. We've now got 9 different treatments across 4 different pathways, so it's been a real success story over a fairly short period of time. I quite also like the Lego analogy. As a father of 2 boys, I can tell you the pain of standing or kneeling, even worse, on Lego bricks is a bit reminiscent of some of the challenges that we've had along the way in getting the treatments for pH online. So this is a timeline, and this shows just the evolution that I've just been talking about. And so you can see on the left side there, the first PGI2. PGI2 is an abbreviation for prostaglandin. So that's iloprost, epoprostenol, treatments like that. The first oral ERA, we'll talk about ERAs later, endothelin receptor antagonist, that's bosentan, that's the first one. And the first PDE5 inhibitor is sildenafil. Cyclic GMP stimulators, that's riociguat. We're going to talk about all these as we go. But not only have we seen the development of these individual treatments, but an understanding of how best they're used. And we've gone from a situation where we primarily use one treatment to using different combinations. We've also seen a sort of a generation change and an evolution in the patient population. So we've gone from managing a very acute condition and just treating people when they're very, very sick to now a chronic condition where people are living for many, many years with pulmonary hypertension, which is a real development. But it's presenting further challenges. So with older people, perhaps more comorbidities, more different conditions wrong with them, and also a longer list of prescription medication and other medications that we need to check that everything works well with. So there are different challenges now than we had back there when there was just only one treatment available. So it feels a bit like a jigsaw puzzle, and that's, again, why I've been invited to come and just explain a bit about the treatments and how they all fit together, and where some treatments definitely don't fit together and which ones not to use. So what we'll do is I'll walk through and explain a bit about the treatments, how they work in general and specific terms. So if we start with supportive treatments, and again, I use some abbreviation TX just because it fit in the box, but TX is an abbreviation for treatment. So if you see one of the doctors or physicians writing in your notes, TX, that's just short for treatment, okay. It's a useful abbreviation, and supportive treatments are the sort of treatments that not everybody is on, but people will usually be assessed for, so such as oxygen, diuretics, and anticoagulation. So not everybody will need all of them. Some people might need one, or some people might need all, but it's all tailored to the individual need of the patient. In terms of anticoagulation, we're seeing an increased use of a newer treatment called a NOAC, so that's novel oral anticoagulants, blood thinner. Treatments such as rivaroxaban, apixaban, and edoxaban, these are used to thin the blood, so similar to warfarin, okay? There's no monitoring needed, which is great, because if anyone's had warfarin, they'll know they need to get a regular blood test. So there's no monitoring needed with the NOACs, but your kidney function has to be quite good, otherwise the NOACs can't be cleared out of the body appropriately. So it's an individual need for anticoagulation. People with idiopathic disease will have a survival advantage on warfarin, and increasingly we use NOACs, as I say, for simplicity. Other forms of PH, the evidence is less clear, so that's a decision for the doctors and yourselves to decide whether anticoagulation is right. Obviously, patients with CTEPH, so that's chronic thromboembolic disease, where there's been blood clots in the lungs, they'll always need anticoagulation. Moving on to the first-line treatments. So patients, when they have a right heart catheter, which is the test to measure the pressures in the lungs, patients with idiopathic disease will also have a gas test, or sometimes an injection test, to see if their vessels vasodilate. And if they're found to vasodilate and respond to that challenge, then they'd be good candidates for treatments such as diltiazem or nifedipine in quite high doses. Those are vasodilators, so they open up blood vessels. If the test is negative, or you have a form of pulmonary hypertension that wouldn't likely respond, then you'd be moving on to the other treatments, such as PDE5 inhibitors, sildenafil, etc. Now, Wendy and Carl sort of mentioned a bit about this, but just to give you an idea in terms of how the drugs are working, this is a nice picture here. So on the left, what you can see, if you can imagine down through the vessels in your lungs, patients with pulmonary hypertension their vessels will look a bit like the ones on the left. So we've got a thickened wall. There's a lot more muscle, if you can see, around the tube. And the canal where the blood is actually flowing down through is a lot narrower. And what you can see are the little red blood cells. They'd normally be clearly traveling in a liquid, but they're little red blood cells coming down through. On the right side, you can see that the vessel wall is a lot thinner, a lot more stretchy and elastic, and can respond when the body's doing exercise, can open up more easily, allow more blood to push through. If you want perhaps a more easy to picture real life example, then I quite like this one with motorway contraflows, or maybe an accident, where what we've got is a lot of traffic being forced down into a much lower area, so into maybe 2 or perhaps 1 lane. And what happens is then that the blood is obviously flowing slower, less is getting through, and the pressure builds up behind. So we can all hopefully picture that. And what we'd like with our pulmonary hypertension treatment is that we've opened up those blood vessels. So what we've done is remove those cones, remove the roadworks, and allowing the traffic and everything to move through much more smoothly as we would like. And so that's what we're aiming for with treatments like sildenafil, tadalafil, diltiazem, nifedipine. These are opening up blood vessels, and in doing so, what they do is reduce the load that the heart is having to push behind. Now, a lot of people will hear the phrase oral combination or oral combo, and what that means is the addition of a second treatment on top of your vasodilator, and usually that's the addition of a treatment called an endothelin receptor antagonist, so such as bosentan, macitentan, or ambrisentan. And this is really where the best evidence is for the treatment of most people with pulmonary arterial hypertension. What we've talked about already with the vasodilators is the little diagram at the top, so you can see that we're opening up the blood vessels to allow more blood through. What the ERAs do is complement this action by further stopping the further narrowing down. So they're stopping that vasoconstriction, that tightening, the further thickening of the blood vessel wall, so they work in tandem with each other, and that's why they work well together. Receptors is often a complicated idea. When we talk about endothelin receptor antagonists, what does that mean? Right, well, there's a series of receptors around the body, and they work a bit like a lock and key. So you can see that when we got the wrong key there, it doesn't activate the padlock. And when you've got the right key, then it opens the padlock up. So that's a little bit away of how drugs are working. So macitentan, abrasentan, and bosentan are all looking for these endothelin receptors and stop the endothelin from working. Okay. So these are all cover pages from the medical literature. So these are the results of clinical trials, and you can see that we've got abrasentan plus tadalafil. That was one of the first combination studies. You'll recognise there's the author list beneath. Some of you will recognise some of the names from the UK centres. But what it shows is that there's lots of big clinical trials all showing the benefit of using oral combination treatments. Okay. And it's important to note that in the UK specialist centres, we were involved in recruiting patients, contributing to the research in all of these studies. So moving along our jigsaw, the third oral therapy is selexipag. It's been available since April, and the challenge in getting it commissioned on the NHS is not to be underestimated. Ian's alluded to it earlier. Thanks to the patient voice, thanks to the stories that you've put forward, then we were able to go with the PHA as clinicians to NHS England and campaign to get the drug available. So it really has showed the power of the patient voice, and going forward, I suspect this is going to be more and more crucial as budgets in the NHS get tighter and tighter. Selexipag works in the body like a prostanoid. I'll come on. That's another vasodilator. We'll talk about more prostanoids as we go. But what the data in the clinical trial showed is that it stopped people getting worse, and the phrase is delaying clinical worsening. So what the trial looked for is it slowed the time for people getting worse in terms of reducing their walk distance, their functional class, or their need for extra treatments. Now, I mentioned about receptors around the body. The amount of selexipag that you need largely depend on the amount of receptors around your body, and that's a very, very individual thing. I've got this dimmer switch, or it might be a volume control, depending on how you want to think of it. But the crucial thing with selexipag and a number of our treatments is that the dose is really a bit like turning up a dimmer switch, turning up the volume control. It's not a simple switch on with one dose, switch off. All right. This is quite a nice analogy. So if you imagine that this house is your body, then the room in the top right where the lights come on is your lungs. So what ideally we would like is a treatment that works specifically in the lungs. Unfortunately, lots of treatments, including selexipag, don't work just there, and they have side effects around the body. But if you wanted to not waste energy and not light up the rest of the house, then you would just want a treatment that works specifically. So, picture of my house. Meanwhile, in Ian's mansion, he's got all the lights on. The analogy here is just that whilst we might want to just read a book in one room and just put the lights on in one room, what we've had to light up the whole house. Okay, so if you think of this in terms of what we call systemic side effects, so whole body side effects. So we might just want to vasodilate the lung vessels, but actually what we get is a load of side effects such as nausea, diarrhea, headache, low blood pressure, all sorts of problems all around the body. Okay, so what we're looking for as drug development is much more cleaner treatments that act in a certain place and don't cause these wider side effects. This is the cover from the publication of the clinical trial, and so if you see these kind of journals in clinics, then you'll know what they are. But this was the largest ever clinical trial undertaken in pulmonary hypertension. There's over 1,000 patients, so in a rare disease, that is a massive trial all around the world. And again, all centres in the UK recruited to this study, so that was crucially important to getting the numbers up. There's a titration of 8 to 12 weeks for selexipag, so when the clinic and you decide that you want to you'll be the right person for selexipag, then you would have the first dose and then would have the dose titrated up, which means pushed up over a period of 8 to 12 weeks. As I said earlier, there is a fair amount of side effects. These are manageable, and so often patients will leave from the first dose with some other medications such as paracetamol, treatments for sickness, diarrhea, just in case those become an issue. The maximum dose is 1,600 micrograms twice a day, but it's very patient-specific. So you don't need to get to 1,600. You get to the dose that's right for you when you're not getting side effects. And you shouldn't feel it's a failure if you don't get to 1,600. To use another analogy, this is a bit like going out in the sunshine, all right? So I like to sit out in the sun. I can sit out all day, and that's fine. My wife likes to sit in the shade, and after about an hour, that's enough for her. So it's very, very different between different people, and it's impossible to predict. But we get you up to the highest dose that can be tolerated. The last oral treatment is riociguat. So riociguat works on the same pathway as sildenafil and tadalafil, so you won't ever find them prescribed together. If you've tried sildenafil and it didn't work or it didn't suit you, then we can try riociguat, but we wouldn't be on them together. It's the first treatment to be shown to be beneficial for chronic thromboembolic pulmonary hypertension, and about 75% of patients in the UK on riociguat have got CTEPH currently. So that's where it's mostly prescribed. It's not necessarily less effective or of any less benefit with pulmonary arterial hypertension, but because of the place in the jigsaw where it fits, there are other options and other things we can do, which is why it's not so much favoured. But it does have some theoretical advantages over sildenafil, so it's worth bearing in mind. Riociguat works having followed another dose titration, but the vast majority of patients get up to the top dose of 2.5 without any problems. The main thing with riociguat, because of the powerful way it opens up blood vessels, is it can drop your blood pressure. So patients, when they start on riociguat, go home with a blood pressure cuff, and we monitor blood pressure. There's regular contact with the centres every week, make sure you're feeling okay and make sure the blood pressure hasn't dropped. And that regular contact with the centres for the likes of Selexipag and riociguat is absolutely crucial for the safety and security of the patients, and also getting people to the right dose, managing their side effects. So if we go back to the sort of dimmer switch, the volume control, if you're sitting in a dark room, you might not want to just turn the lights up full all at once. You might just turn them up slowly, similar with the volume. You don't want to turn your stereo up massive straight away. You might want to turn it up steadily. So that's the same way that we get these drugs up slowly and steadily to the right level for you. That's the oral treatment. It's going to move on to the slightly more complex treatment. So this is nebulized iloprost. It's delivered direct to the lungs, but you have to take it 6 to 9 times a day to get maximum benefit from it. And that's because once iloprost is in the system, the body breaks it down very, very quickly, so it doesn't last so long. Giving it 6 to 9 times a day means it has a really big impact on lifestyle. So if you're working, if you've got family, if you're out driving a lot, you just need to think about how a 6 to 9 times a day dose can be fitted into your lifestyle. We've got a lady that's been on it since 2005, so it's a very effective treatment if you can get it to work for you. On the screen here is a picture of the new device, which is called a Brelib device. And the advantage over the previous nebulizer is it brought the cycle time, so the inhalation time, down from about 10 minutes down to 2.5. So it's been a real step forward in terms of making it much more patient-friendly. In terms of treatment, this is the last stop, and this is our most complicated treatment, but also the most potent. So IV prostanide, reserved for our sickest patients or those that are deteriorating most rapidly. Because of the need to learn how to make up the pump, the drug, look after the line, then patients come in for a protracted stay in hospital, because everybody's got to be completely independent with the pump and everything before they can go home and feel safe. Once they leave the hospital. Usually when people are considered for prostanide, we'll also be discussing with them about transplantation referral to get people assessed. And it does require this pump to carry around with you. So not to be underestimated. Epoprostanol is the licensed approved form in the UK. There's 2 different brand names, Flolan 12 and Velitri. Iloprost works in exactly the same way, slightly different pump, but other centres use that. Works in the same way. So completing the outside of the jigsaw, we've got the specialist centres, and they play a vital role in the safe delivery of care across, because PH is such a rare disease, you need expertise. So when I came in, there were some doctors, there were some nurse specialists, there's now a group of pharmacists, there's expert radiologists who look at all your scans and tests to see, but increasingly now there's physiotherapists, there are anaesthetists and surgeons who are developing an interest in pulmonary hypertension, again because we've got people who are living longer with this condition, then elective surgeries such as knees, hip replacements becoming a necessity. So experts in managing anaesthesia and operating on people with PH, previously thought to be impossible, is now becoming much more of a reality. So developing that expertise at those centres. The NHS specialist centres are the envy of the world. When you go to any conference, people in the States, people from Europe will tell you that this network of expertise is really the envy. This is a map of our PH professionals group. So that's the group of pharmacists, nurses that we meet twice a year. There's a similar group of physicians who meet twice a year to ensure that best practice is shared amongst us. And also the national centres play an important role, as I've alluded to earlier, in making clinical trials available, so making the new treatments and any developments available to you all first. Now, can anyone guess what's going to be the last piece of my jigsaw? PHA. Yeah, very good, you guys. All right. So holding it all together is the PHA. It is without doubt a huge support to the pulmonary PH professionals group, the physicians group, to you as patients, and to all the centres in terms of the care they provide. There are loads of initiatives that they are going on behind the scenes, lobbying at Westminster to MPs to make them aware of treatments for rare diseases, making them aware of the needs of specialist centres. And, 20 years ago when Ian and a few people sat around a table, the distance and the travel that they've come along to 5,000 members to this, it is fantastic. So I want to say personally, and also on behalf of the PH Professionals Group and you guys, can we just show some appreciation for Ian, for Sean, Helen, and the guys working behind the scenes at the PHA? So, are we nearly there yet? In terms of a journey, I'm just going to allude to just finish off here, Ian, and then you can have a minute. But in terms of the journey, I'm going back to my boys and their Lego. Are we nearly there yet? No, we're not. But it's been an exciting journey. We are all travelling together, with the PHA behind us, supporting all the way. Then it really brings us to that theme of stronger together. So, thanks for your attention.
I thought it was going to be something really embarrassing. Just on this theme of a journey, one of the things that some people will know, because we've got it on social media, is something your brother's doing this weekend on our behalf.
Yeah.
I'm just trying to say what it is, and then I think we're going to be able to bring his position up on screen.
Yeah, we're on. Yeah, so my brother's an avid cyclist. He's done all sorts of crazy cycles, and he told me last year that he got a place on the London to Paris 24-hour cycle challenge. So I said, why don't you raise some money for the PHA? Well, I'd be delighted. So basically, Rob there is his map. He's sort of heading through France as we speak. He set off from Greenwich yesterday at about 3 o'clock. He rode 100 kilometres to the coast to Newhaven, where they got a ferry across to Dieppe, and then they're riding from Dieppe to Paris today, and they need to get there by 3 p.m. So to date, I think he's raised nearly £1,300 for the PHA on his ride. I've had a few text messages. His legs are feeling strong. I don't know how after that distance, but yeah, fantastic.
Cheers. Thank you.